We're excited for today's session and presentation and conversation with the team from Tropical Data. Today's session will include a series of short presentations followed by a 15-minute question and answer session. A few points on housekeeping slide, please, is you'll notice that everybody will be placed on mute. The session is being recorded and we'll be ready to share this recording with the broader ICTC membership after the webinar session. We'd also welcome questions from the audience, so please feel free to put your question forward. You can do this by raising your hand after the presentations, or alternatively, you can send your questions over into the chat box. Next slide, please. And the next one, please. Thank you. Today's webinar focuses on Tropical Data's work to include new methods to address endgame challenges for trachoma. As many of you will know, Tropical Data is a service that supports health ministries worldwide to conduct globally standardized high-quality trachoma prevalence surveys. As more countries reach the trachoma endgame, new methods are needed in order to best support trachoma elimination programs. Recently, Tropical Data has added 3 new such methods. The first being the use of photography and image grading and accompanying adaptations to training methods. Secondly, the incorporation of infection serology data collection into the Tropical Data service, for example, to help understand unusual epidemiologies such as districts with persistent or recrudescent trachoma. And thirdly, the incorporation of model-based geostatistics into the Tropical Data service for survey design and results analysis to help generate more precise results. So without further ado, today's speakers, I'm delighted to introduce from the Tropical Data team, Emma Harding-Esch, Christina Jimenez, Michelle Taylor, and Anna Hart. Over to you guys.
Thanks, Aparna, and thanks everyone for joining today. And first, I'd like to thank ICTC for inviting us to give this webinar. And also, we're honoured that this is one of Aparna's last activities as project manager. We're going to miss you, Aparna, but thank you for all your hard work over the years in ICTC. You've already given an outline of our agenda for today, so I won't repeat this in the interests of time. But before I get going in terms of Tropical Data and what it is, I just wanted to acknowledge that today is Tropical Data's 8th birthday. 8 years ago, saw the first Tropical Data supported surveys taking place following the end of the Global Trachoma Mapping Project. And we wanted to thank everyone who has been part of this work and who supported countries with surveys. So here is a reminder of the standardized epidemiologically robust Tropical Data methodology, which builds on that developed and used for the Global Trachoma Mapping Project. So as Aparna said, we support health ministries from the start to the end of the survey process. We have protocol review by dedicated epidemiologists, ensuring it conforms with WHO recommendations. There's project planning and budgeting, technical configuration of phones, which are used for data collection, and phones are sent to countries. We have standardized training, adapted from the Global Trachoma Mapping Project devised training system, including certification of graders and recorders. Data are collected on Android smartphones, and the data are uploaded to a cloud-based server using secure encryption and authentication. And there's automatic data analysis using purpose-built algorithms. And the Tropical Data Survey is one that involves all of these elements and not any one in isolation of the others. So using these methods to date, we have supported 3,706 surveys across 52 countries. And just to finish off, just a reminder that the core Tropical Data team includes staff from the London School of Hygiene and Tropical Medicine, the International Trachoma Initiative, Site Savers, and RTI. We also have a global network of trainers and of course work closely with countries their partners, and other institutions such as WHO. And I will now hand over to Christina to speak about photography.
Hi, so yeah, now we'll move on to photography and the changes to our training methods. So the issue facing us, as countries move towards elimination of trachoma as a public health problem and prevalence declines, we've become the victims of our own success. It's become increasingly difficult to train new graders and to recertify existing graders using live cases and the methods we've become accustomed to. So, for example, within tropical data, as fewer cases are found, it became harder to pass the Intergrader Agreement, or IGA, test that was part of the grader training. Within countries, teams have to travel further afield to remote areas to find cases. And in some cases, graders have had to travel to other countries for training, which is expensive and unsustainable in the long term. We therefore proposed a workshop bringing partners together to look at how photography was currently being used for trachoma and to discuss how it could help us to future-proof trachoma diagnosis for prevalence surveys. We approached individuals we knew who were working on photography and asked for recommendations of others and invited them to an initial workshop that we had in July 2020. This led to a series of different meetings, workshops, and working groups focusing on different uses of photography, with various organisations taking the lead on different activities. And a report on some of those activities can be found on the ICTC website. One activity that has been led by Tropical Data was the development of a photo database, a central repository where partners can share photos of the eye. It's a resource that can be used by the whole community to support education and research efforts for trachoma elimination and long-term surveillance. The database is now live, with over 3,000 photos having been shared already, and the aim is to collect photos with a variety of clinical presentations, including borderline photos. And we're always open to more photos if your organisation has them. Irrespective of any previous grading, all photos that have been shared are consensus graded by Tropical Data principal grader trainers. So we have a standardised grade for all of them. And the database is managed by the Tropical Data team on behalf of the trachoma community. And we have a steering committee made up of health ministries, NGOs, and academic partners to help us with that. So Tropical Data has used some of those new photos from the database to help update our training processes. So we no longer have to rely on live cases of TF when conducting field IGAs. The main changes have been to the grader certification process, which now includes a follicle identification exercise where trainees have to identify follicles in photos of TF, an initial phone-based IGA test with 50 clear-cut images to show they can accurately diagnose TF, a second phone-based IGA with 100 borderline images to show they can diagnose in harder to diagnose photos. Borrowing from our dedicated TT-only training system, there's a more formal assessment around the diagnosis of TT and TS. A classroom-based OSCE to demonstrate good examination techniques. And finally, a field-based OSCE to demonstrate good examination techniques on individuals of various ages, including children. So what does this mean in practice? I think given our audience today, we have a lot of implementing partners. I wanted to go over some of the implications that these changes have on your survey planning. So for instance, you no longer need to conduct case finding in advance of training to support field IGAs for graders. The new agenda has been designed so that graders make use of the Android phones on the first day of training to complete their phone-based IGAs, and then the recorders use those phones from day 2. For the grader certification, there is an element of field work still, and that is in the form of the examination technique practice and the OSCE in the field, ensuring graders are able to demonstrate good examination techniques on all ages, especially children, given that's not possible in the classroom. These sessions obviously still require some planning and identifying those sites in advance before the workshop starts. And then the final day of the training workshop still involves team practice in the field with graders and recorders working together, which again needs that advanced preparation and identification of those field sites. There is no formal requirement anymore to identify cases of TF or TT in advance of the field work. However, if during planning or during those field visits, any cases are identified, ideally permission would be sought to have the graders examine those individuals to make the most of being able to see those live cases. And some other changes to be aware of, more generally to our training methods. One is if trichiasis is present in either the upper or lower eyelid, in either eye, the grader will need to count the eyelashes, either touching the eyeball or epilated or both. This will be recorded in the resident examination form and is a way to strengthen TT diagnosis. There is also an optional question at the end of the resident form that now asks if there are any other eye conditions graders wish to highlight for treatment or referral. And this avoids anyone being recorded as TT present in order to get a referral when actually they may have another condition. And that's it for the summary of our training updates.
Okay, I'll take over then. Hello, everyone. I'm Michelle Taylor. I'm a project manager at Tropical Data. And today I'm presenting on some of the adaptations being made to the Tropical Data Service to incorporate the collection of serology and infection data. Can move on. To provide some background, over the last year, Tropical Data has been preparing its systems and processes to be able to offer a broader package of support for countries wanting to conduct serology and/or infection testing as part of routine trachoma surveillance surveys. So here I'm referring to a subset of so-called plus surveys, where ocular swabs and/or dry blood spots are collected to test for CT infection and/or antibodies. And these sample types are collected because TF isn't always a good proxy indicator of current infection, especially following mass drug administration. And while for most countries this won't matter too much, for the small number of countries that are experiencing problems like persistence and recrudescence, it was agreed at a WHO informal consultation in December 2021 that there was a need to explore more tailored approaches, and complementary indicators like serology and infection testing provide new data to help tailor interventions. Another important piece of background information is that the World Health Organization is preparing to convene a guideline development group, which we expect to make recommendations on how serology data might be used to support trachoma elimination. As Tropical Data, we of course aim to support countries to conform to WHO recommendations. So the preparation work we're doing now is aimed at ensuring the support we offer remains up to date. Next slide, please. Tropical Data has, of course, already supported countries to conduct lots of plus surveys, but so far these surveys have been categorized as operational research, and this has really limited the type of support the Tropical Data can offer. So the work we're undertaking now aims to prepare Tropical Data to support plus surveys through an end-to-end process, starting with the established methodology, through planning, training, field support, data cleaning, and the provision of results. And a really important facet of this work is to standardize certain elements of the survey process. So for instance, the sample collection techniques, the trainings and the data analysis, so that data from PLUS surveys are of consistently high quality and comparable across time and settings. In determining what changes to make, Tropical Data has undertaken 2 measures. The first was a scoping review. Here, we reached out to partners who already had extensive experience conducting PLUS surveys, and we asked them to share both their resources and their experiences. And this was done with a view to taking forward best practices. Next slide, please. The second way Tropical Data has been assessing what changes to make has been to support the 6 country recipients of a core NTD grant, which is aimed at understanding the underlying causes of persistent and recrudescent TF. And this is proving to be a fantastic way to strengthen Tropical Data's capacity in PLUS surveys. Next slide, please. So in terms of putting what we've learnt into practice, this is a summary of some of our project activities to date. We're working on producing a standardized protocol to accompany Tropical Data's existing protocol writing guide. So here we're setting out things like the standard operating procedures for collecting and storing specimens, and we're providing guidance on the additional information we'd like to see in country protocols for PLUS surveys. We've drafted a number of supplementary training materials, and we've reviewed Tropical Data's survey forms and found them largely fit for purpose, but we're also attempting to add more checks and balances where we think we might be able to help minimize some of the errors that can occur around specimen management. We're also developing new data cleaning checks, as well as a number of new supportive resources. I'd also like to mention that this year Tropical Data is planning a major update to our IT systems. The planned update seeks to improve and modernize the current IT system to accommodate the new data flows associated with serology and the Geostats project we'll hear about shortly. But it also seeks just to create more flexibility for code changes to be made in-house and to future-proof our data management system for whatever innovations are yet to come in support of trachoma elimination. During this preparation stage, we've been making good progress, but just to underline that some of our work is contingent on external factors. So in the coming months, we're going to be continuing to learn from our involvement in the core NTD projects. We're also waiting on that meeting of the guideline development group and some of the recommendations that we hope will come out of that. For instance, we would be interested in hearing about thresholds for serology work so that we can start to think about getting analysis code to process that data. Next slide, please. So to summarize, Tropical Data in this area is in a planning stage. We're preparing our processes and systems to be able to support PLUS surveys through an end-to-end process. However, and this is a very important point, we will now await the recommendations of the WHO guideline development group before implementing any of our changes. Finally, I'd like to conclude by emphasizing that even after the WHO meeting has occurred, we don't suddenly expect PLUS surveys to be carried out everywhere all the time. They will likely only be used to address a small number of use cases. So for instance, post-MDA surveillance or for baseline surveys to confirm new trachoma endemic districts, and for use in districts where that epidemiology is a bit unusual. So for instance, where persistence or recrudescence is suspected. So I'd like to thank our project funders, the Bill and Melinda Gates Foundation and USAID, and I'd also like to thank you for listening. I'll now hand over to Anna Hart.
Hi everyone, I'm Anna Hart and I'm the project manager for the incorporation of model-based geostatistics into the Tropical Data Service for survey design and results analysis. So to give some context, the current standard TD method uses a design-based analysis approach where surveys are designed to have enough power to accurately estimate TF. However, when there are low levels of TF or TT, estimating the prevalence becomes more difficult and there is less precision. It is also impossible to estimate the prevalence of trachoma in areas where surveys cannot be conducted. Model-based geostatistics is a possible solution to some of these issues as an enhancement of current survey methods. Model-based geostatistics, or MBG, is a branch of spatial statistics. Unlike non-spatial methods, spatial statistical methods can account for spatial correlation, which is where locations that are nearby to each other are more similar relative to locations that are further away. And trachoma prevalence, for example, tends to cluster spatially. This spatial correlation means we can use data collected from sampled locations to inform prevalence at nearby unsampled locations. There are two main benefits to using MBG. The first is MBG can create more efficient survey designs using spatial correlation to identify the best locations within an EU to survey to maximize the information gained from the data collected. Secondly, MBG can improve the precision of the prevalence estimates. There are substantial improvements in the precision because the information provided by the spatial correlation reduces the uncertainty in the data. And the paper shown here is a study that demonstrated that MBG can substantially increase the precision of prevalence estimated for neglected tropical diseases. So how is MBG being incorporated into the Tropical Data Service? Tropical Data were awarded a grant in collaboration with Lancaster University in May 2023 by USAID via the Task Force for Global Health. Lancaster have been investigating the use of MBG in the context of NTDs for some time, and they are currently responsible for all trachoma MBG data analysis and survey design. We are still very much in the research phase of working out how and when MBG can be used for trachoma elimination purposes within the Tropical Data Service. So currently, MBG for either survey design or data analysis must be requested by contacting Tropical Data or Lancaster University directly. Current research that's going on includes developing the criteria for running MBG models, depending on the request type and context. Research on the inclusion of covariates into the models is being finalized. It's been going on for a while, with current results indicating that it is highly likely that semi-bespoke models will be needed. Training materials are also being developed on how to use and interpret the MBG outputs. And the tropical data system is being updated to allow for the inclusion of new modeling techniques and MBG survey requests. The long-term plan for MBG is to use it as standard in all TD-supported surveys. To do this, we will need a full-time member of staff able to manage, implement, and validate MBG requests. Models will ideally be somewhat automated, but will still require some manual checks at various stages. And as previously said, it is highly likely that semi-bespoke models will be needed. Future research into the use of MBG for post-validation and surveillance, persistent recrudescent EUs, and inaccessible EUs is also planned. And that's everything from me, so I'll hand back to Emma.
Thank you. Just to flag that on the Tropical Data website, there are some MBG resources if you want to explore this area in more detail, including a webinar that was held last year for a bit more detail of MBG methods and some use cases. We've come to the end of our webinar. Thank you everyone for attending. We are always at Tropical Data adapting and learning in response to feedback, research, international guidelines and recommendations in order to innovate and help drive evidence-based methodologies to best support health ministries. So today we presented some of the major changes we've been working on in the last couple of years, and we welcome your questions and feedback both now in the Q&A but also in the future. So thank you all for your attention, and if you've got any questions, either put them in the Q&A now or you can email admin@tropicaldata.org.
Thank you very much. We do have about 12-13 minutes for question and answers. I'd like to encourage attendees, if you do have a question, please feel free to indicate your hand up in the Zoom, or alternatively place questions in the chat box function. While we're waiting for questions to come through, perhaps I might get us kick-started by asking whether these new methods are available and on offer to health ministries now.
I'll jump in as my camera flashes. So as Christina indicated, the photography work is available. It's routinely implemented now. As Michelle indicated, the serology and infection data collection is kind of a bit hybrid. We've been supporting partners and countries as operational research, but that routine implementation from the start to the end of the survey process is not available. And we have a similar issue, as Anna indicated, that to be able to offer that as a routine part of the service, we would need additional personnel. It's complicated and very resource intensive. And as Anna indicated, for the MBG analyses, we are still in the research analysis stage. We have supported some countries, but again, it's beyond the capacity of the existing team, and there is still a lot of research to be done before we can implement it as routine. Next week, Lancaster University, which is a WHO collaborating centre, is hosting a meeting which several of today's participants are attending, where we're going to be discussing MBG in more detail and getting feedback from the community regarding some key questions around its utility and future research and implementation issues for it to be implemented as routine.
Great, thank you. A question from the chat box asks, how do you access the draft agenda for the Plus component?
Hi, I'm thinking that maybe you are referring, is it Stephen asked that question?
Yes.
To what we will eventually release as our standardized protocol. So this will be the guidance for how to, for the additional elements that are needed in a Plus protocol. That's in a draft phase at the moment. Again, we need a few elements to complete our work and to finalize that draft. But if anyone is looking for advice at this point on how to put Plus protocols together, please ask for support on request, and we'll do our best for you. But at the moment, we don't have that standardized guidance that we can give out en masse. Thank you.
Thank you very much. Another question from the chat box. How will village level data delineation be used for MBG, as re-administration frequently happens in some countries?
So I'm guessing this is kind of talking about boundaries of villages, and this is actually a really quite a big problem that we have hit a few times, and that if we don't have accurate and up-to-date shapefiles, MBG can't be used. And that's something that we're developing. So we're looking at the different criteria that kind of are, black and white. If we don't have certain criteria met, then we can't run MBG. So it's very important, yeah, and something that we're working on to try and possibly fix. But it's a work in progress for that, yeah.
Thank you very much. You mentioned during the presentation that there is a collaboration between Tropical Data and WHO. Can you share a little bit more information on how that collaboration informs guidance going forward?
Oh, go ahead.
Parna, is that in relation to one particular new element, or all three elements?
Across all three.
Okay, Christina, you start.
Well, I suppose with training, as we sort of already discussed, we sort of follow the sort of WHO guidelines that are out there for trachoma prevalence surveys. So yeah, and as those might evolve in the future, then we'll look to evolve with them.
For the serology work in particular, obviously we're waiting on that meeting of the WHO guideline development group. And again, the sort of outcomes we are expecting or hoping to see from that would be things around the thresholds for what would be important, diagnostic thresholds to see for serology, and how that might guide programmatic use. So we are preparing our systems, but we are very much waiting for the WHO to lead the way on that. So we hope to see that meeting happen this year.
And in the context of MBG, Emma's actually already mentioned that next week we have a meeting organised by Lancaster University, who are a WHO collaborating centre. And obviously we're working very closely with the WHO, but just to again emphasise that we want insight and input from a wide variety of people about how we implement and when we implement MBG. But yeah, so that'll be next week in Lancaster.
And are there, just following up on that, are there other opportunities to receive inputs outside of the meeting that's happening next week at Lancaster?
I mean, obviously we're always open to receive communication from anyone. In terms of formally organised, no, but we are pretty certain that we'll probably have to organise a lot more meetings in the future. We won't get all the answers to the questions that we have next week. This will be one of many meetings, no doubt. And we hope to invite more people down the line to get involved in how we decide how MBG is implemented.
Wonderful, thank you very much. Another question I had was also around whether there was a way some of these new methods could be used to integrate other disease data collection, and whether Tropical Data had any examples of NTD integration currently occurring right now across all three.
I'll get the ball rolling on that. Yeah, I think it's nice to convey how serology testing, so the collection of dried blood spots, really lends itself to conducting integrated surveys, and how Tropical Data fully expects the work that we're doing now to confer benefits to other disease programs. Serology testing for trachoma is carried out in dried blood spots. That's a really versatile sample type that's safe and easy to transport when it's dry, and that can be stored at room temperature. DBS collection is a well-recognized skill already used across disease programs, and it has the added advantage of creating opportunities for multiplexing. So that's where you're testing the blood for several diseases at the same time. Yes, Tropical Data has already supported integrated surveys. We haven't run the analysis on the dried blood spots, but for instance, we supported a survey last year that I won't name, but the DBS that was collected there was tested not just for trachoma antibodies, but for antibodies to another 7 NTDs as well. So we hope to see more opportunities like that happen in the future. Thank you.
In the context of MBG, as I showed at that paper, the screenshot of the paper, it's entirely possible to use MBG, and it has been used in the past to estimate prevalence of multiple different NTDs. However, we would obviously need to have that data to hand in order to use MBG, so TD would need to have that step kind of implemented first. And in terms of there's certain aspects of MBG that we need to determine. So for example, next week we're looking at what certain limits and thresholds of the data, the output that MBG gives you, that we need to kind of work out, and we need to do that for every different disease we would need to do. So it's theoretically possible, but currently we are just focusing on trachoma.
I guess for training, our standard training methods are very much focused on trachoma. Where we do come across perhaps integration with other diseases and some of our operational research, we then work in conjunction with maybe experts from those other fields and sort of look at how we adapt and integrate those processes together. But for the moment, those are focused on trachoma.
Thank you very much. I have a question from the chat box around how can the serology, photo, and checking questions of graders for a particular client, how do they cross-check or approach the question for precision? So I think that question is really around how do you check the precision of data, or how do you ensure that graders are asking the right questions?
Again, and apologies if I have not understood this question very well. from my perspective and for the perspective of my project focus, I'm thinking how serology and infection data helps give us a clearer indication of active CT infection, as we know that TF can be this lagging indicator. So I'm hoping that is what maybe can be inferred from that question, and that's what we are hoping going forward, that programs can spend potentially or less money on mass drug administration if it's no longer needed, if that TF is a lagging indicator, then the serology and the infection data should flag that up. Thank you.
Wonderful, thank you very much. We have one final question before we close our session, and that is a broader question to the tropical data team on what are some of the cost implications of these new methods for tropical data for affected countries, health ministries, and for partners.
Can you hear me?
Yes, we can.
Okay, sorry, I thought I had a thing that said my audio had gone. From the photography training side, the cost implications are that things are cheaper because you no longer need to base your training in a trachoma endemic setting, and you no longer need to do that case finding beforehand. And there's really limited additional costs in terms of the existence of the photo database or of doing the classroom-based training. From serology and infection data collection, the initial cost is clearly much more because you have to add, for example, additional people to the field teams, you need all the materials, you need to do the lab testing. However, the idea is that it is cost saving in the long term, not only because you have a greater data set and a richness of data, but also because TF is not necessarily a good indicator of CT infection. It can hopefully avoid unnecessary MDA rounds in the future. So the idea is that it's cost saving to programs in the long run. And then in terms of the geostatistics, again, the idea is that it is for the community cost saving. You have more efficient survey design and more precision around prevalence estimates. There is an increased cost to tropical data or those running the analyses because there needs to be an additional person in order to be able to do that work.
Wonderful. Thank you so much, Emma. It's been really interesting. Thank you so much for today's presentation by Tropical Data. And I think the presentations and the conversation really highlight the growing recognition of the need to continue to innovate and adapt to meet endgame challenges. It also showcases opportunity for integration with other NTDs, supporting national health ministries to achieve both their trachoma and their wider NTD ambitions. So please join me in thanking Emma, Christina, Michelle, and Anna for presenting on behalf of the Tropical Data team today. Thank you to everyone joining today's session and engaging, learning, and sharing your thought-provoking questions. We'd love to invite ICTC members. If you'd also like to present on a future ICTC webinar session, please get in touch with Tim at ICTC, and we'd love to share the work that you're doing with the broader community. So with that, I'd like to say thank you very much, everyone, and have a good rest of the week.